Auzubillahi minash shaitanir rajeem. Bismillahirrahmanirrahim. I am Dr. Shahzad Waseem. I am making this small video because many students are asking questions about this topic, and that is uveitis. So basically there are three types of uveitis. As I told you that whenever you want to study any sort of eye disease, keep in mind sagittal section of the eye. This is cornea, this is sclera, this is iris, this is lens, and here are the suspensory ligaments. This is the middle, it, it should be in red color, middle layer, which is the choroid, and this is ciliary body, which is also vascularized, and iris is also vascularized, and the innermost layer is usually drawn in the pinkish color, that is neurosensory retina, and this is sclera, this is cornea, this is anterior chamber, and this is pupil. And uveitis is defined as inflammation. There are three types of uveitis which can be classified on various basis. The most important classification is anatomical classification. Anatomically, if only there is inflammation of the iris, it is called anterior uveitis. If there is only inflammation of the ciliary body, it is called intermediate uveitis. And if it is only the inflammation of choroid, it is called the posterior uveitis. This is the basic classification, and I will tell in this short video mostly about anterior uveitis, and which is the most important for fourth year MBBS students, and a little bit about intermediate and posterior uveitis. Regarding anterior uveitis, it is the inflammation of the, as I told you, of the iris. This is cornea, so for example, this is iris, and this is anterior chamber, and this is the sclera. Now, inflammation of iris is called the anterior uveitis, which is the most common uh, type of intraocular inflammation, and the most common cause of anterior uveitis is idiopathic. The second most important cause of uveitis is because of some trauma, and sometimes uveitis is associated with systemic diseases, but usually the posterior uveitis is associated with systemic diseases like tuberculosis, sarcoidosis, where you will see granulomas on the choroid, as seen in the lungs in tuberculosis and sarcoidosis. Anterior uveitis is usually not associated with systemic diseases. So we are talking about the anterior uveitis. In anterior uveitis, the inflammation from the iris causes the leakage of the plasma constituents because of the breakdown of the um, blood ocular barrier, which is on the anterior part, that is the blood ocular barrier at the iris level. So when this barrier is broken down, the inflammatory cells come into the anterior chamber, and when they come into the anterior chamber, they cause inflammation. This is inflammation simply. Now, what we see on slit lamp, what is first of all, let me tell you the symptom. It can be symptomless if it is mild, or patient may come to you with the pain of with the complaint of dull pain, or patient can come to you with the complaint of blurred vision. Uh, Patient can come to you with a presenting complaint of red, slightly painful one or both eyes. Uh, these are the symptoms, and the signs are: number one, these constituents which are released from the iris capillaries, they contains proteins, they contains mononucleosides, neutrophils, uh, and all these cells, and where they stick to the posterior part of the cornea, that is here, sorry, here in the inner part at the cornea. This is again behind the posterior surface of the cornea, that is on the endothelium. This is the cornea, and these are the capes which are present or stuck to the endothelium, and these are called creatic precipitates. Creatic for cornea and precipitates for, as you know, they precipitate or they जिसे वो कहते हैं जम जाते हैं एंडोथीलियम के ऊपर, दे स्टक ऑन द एंडोथीलियम, so they are precipitates, and they usually are inflammatory cells can use neutrophils and monocytes, plasma cells. And in fresh anterior uveitis, which is acute anterior uveitis, these are visible on the slit lamp as white dots. When the inflammation is resolved, they become pigmented, and they appear brownish in color, and they tell us that patient might had an attack of anterior uveitis many years ago, and after some years they may disappear or they may still be there. So this is the number one sign of anterior uveitis, that is capes. And after capes, the other important signs are cells in the anterior chamber, as I told you. Cells in the anterior chamber, you can see from the book, they are uh, they can be from 1 to 4. How many, depending on how many cells are present in the anterior chamber. It is not very important from threat practical point of view. You can see this classification from your book. I will tell only the symptoms here. So one is KP, static precipitates. Number two are the cells in the anterior chambers, which are again neutrophils and inflammatory cells, monocytes. Then, if cells are not present, uh, then this anterior chamber might have only protein, and the protein is not visible, only a flare is visible, and flare is some what like you can see when in a foggy season you see the light in front of a car, you can see a flare of that. That, for example, this is the light of the car, and you see that from this lightening of the car, there is a flare of light which is visible, and this pattern is visible in the anterior chamber, and it is seen only by experienced ophthalmologist on the slit lamp. And if only flare is present, it is called flare, then it means that the inflammation is very low in intensity because there are no cells. But the signs of uveitis contains capes, uh, cells in the anterior chamber, and flare. Now coming to diagnosis, for the fourth year students, it is important that as the intermediate inflammatory mediators are released, as a result of it, the pupil becomes constricted. This is very important point. Um that is, this is so the pupil becomes constricted. This is in response to the inflammation. Now, the ciliary body, which is attached with the iris, it is also usually involved, and usually we call it iridocyclitis. Irido mean iris and cyclitis mean ciliary body. So they both are usually uh, involved instantly. And even if it is not involved, because of the constriction of the pupil and spasm of the ciliary body, patient experiences uh, dull pain. And the most important symptom is also that when patient goes to the sunlight, he feels photophobia. That is, he cannot open his eyes clearly in the sunlight. Moreover, you can see, as I told you, his eyes will be red. There will be circumcorneal congestion, 360-degree all around the cornea. If this is the limbus, you will see circumcorneal blood vessels here. These are because of the inflammation of the scleral blood vessels and conjunctival blood vessels. Anyways, now what is the treatment? The treatment is based on two main things. Number one, to reduce the inflammation, and number two, to uh, reduce the patient's discomfort, and number three, to prevent the formation of adhesions between the iris and the lens, which is present posteriorly. Sometimes in inflammation, iris gets stuck to the lens, and this situation is called posterior synechia formation or posterior synechia formation. And when it stucks to the lens, it can cause to the formation of cataract formation. Cataract can also occur in the absence of posterior synechia, but we have to prevent it. So what we do in the treatment, number one, the mainstay of treatment is topical steroids. For example, prednisolone, which comes with the trade name of Predfort eye drops, every 2 hourly. Then we can taper off to every 4 hourly, then 4 times a day, then 3 times a day. It depends on the intensity of the uveitis. Even in the beginning, if it is severe, we can give every 5 minutes. But keep in mind that steroids, in some people who we call the steroid responders, in them the uh, topical steroids cause rise in the intraocular pressure after 6 weeks of usage. So we have to monitor the intraocular pressure also. And steroids also can cause the formation of posterior capsular cataract. But this is the only treatment for uveitis. Number one is the steroid, and number two, the main treatment option, the red dot bottles, that is mydriatics. Now, usually, uh, what we give are the steroids in the form of prednisolone eye drops, dexamethasone eye drops, or whatever, and mydriatics in the form of tropicamide, which comes in the name, but the trade name of midrasil, or we give atropine classically and as the prodrug and the primary drug of this region, atropine, has uh, long-acting mediatic, and it causes the pupil to dilate for 10 days. But we prefer tropicamide because it causes dilatation of the pupil for 4 to 6 hours. So it causes the pupil to dilate and then constrict. Again, then dilate and then again constrict. This movement which midrasil causes in the iris when given 3 times a day keeps the iris mobile, prevents the formation of posterior synecdoche, and it also stabilizes the blood ocular barrier. So it has many advantages for stabilizing the inflammation of caused by uveitis. So, not going in more detail, two drugs are important. Number one is steroids, eye drops. Number two, mediatics. If both eyes are involved, they can be given in both eyes. If not controlled with the topical drops, then we can give subconjunctival steroid drops. If is still intractable, then we can give oral steroids. If it is not controlled, we even give sometimes immunomodulators like cyclosporin. Now, the contraindicated medicine in this condition is all those medicines which increase the inflammation. That is parasympathomimetic drugs like um, acetylcholine uh, uh, receptors पे जो एक्ट करती हैं, and pilocarpine is the pro-drug, main drug of this category. Pilocarpine is absolutely contraindicated in uveitis. And remember that pilocarpine is the drug of first choice in acute angle clear glaucoma, when you will learn glaucoma in the coming lectures. And in glaucoma, mediatic is an absolute contraindication as opposed to uveitis. So I hope you will remember this thing, and I will stop here. You can ask questions, and I will be more than happy to see your questions in the group. Or if you feel not comfortable in the group, you can message me, and I will share your message without your name in the group so that everyone can get the benefit. Please give your feedback. Thank you very much. See you later. Allah Hafiz.